Good afternoon, everyone. Welcome to the first DCB Academy lesson of 2025. Today, we have the privilege of exploring a very unique topic, angiographically driven physiology for PCI. Is this the future? Which will be presented by Dr. Giovanni from Spain. Please, Dr. Giovanni, the podium is yours.
Thank you. Good morning. Good morning, everyone. In the background, we know that invasive pressure wire-derived tools have been approved and have gained a class 1 level of evidence A for the selective assessment of functional severity of diameter stenosis, and are nowadays recommended to guide revascularization. What we know is that for invasive pressure wire tools, we have variable reimbursement, the need of intracoronary instrumentation with a variable performance and complication risk, and also the need to induce hyperemia with the associated patient discount for eventually complication, increases time and perceived increases time and increased cost. This has been translated in a low penetration in daily practice, estimated to be between 10 to 20%. For this reason, there have been some angiographic derived FFR tools, and as we can see, those are the ones approved in Europe, and some of them approved by the FDA for the selective assessment of functional severity. The great beauty of having those tools is the opportunity to select and to recommend the revascularization of a lesion based on a less invasive tool. We could have also a comprehensive lesion assessment and the ability to provide multiple FFR values along the vessel, and also some of features such as the absence of a pressure drift and no differences in hydrostatic pressure where we perform our analysis. What we know is that as for FFR, QFR, quantitative flow ratio, has been reported with a class 1 level of evidence B by the current to 2024 guidelines for the European guidelines for the diagnosis and management of chronic coronary symptoms. Those are the tools that we have at our disposal to perform the analysis, and basically the result that we had come from the positive result of the FAVOR 3 China. As for the FFR tool, the result came mainly from the deferred trial. The approval for the QFR came from the FAVOR 3 China, that compared in a head-to-head fashion the QFR PCI guidance versus angiographic guidance. And what emerged is that a QFR guidance strategy of lesion selection improved the 1-year clinical outcomes. And for this reason, we believe the scientific community believed that a QFR could have deserved a class 1 indication. What we know is that a few months ago, the FAVOR 3 Europe has been presented at DCT and received a simultaneous publication in the Lancet. This was an amazing design of the trial, because it decided to compare head-to-head an investigative strategy, the one of a QFR-based PCI versus the standard of care, so the FFR guidance. What I would like to highlight is that this is the first trial that include also patient with NSTEMI and also patient at the secondary evaluation after NSTEMI or NSTEMI or STEMI. This was the first difference that we could highlight compared to the FAVOR China, that included only patient with a chronic coronary syndrome and some with unstable angina. What emerged from the Laboratory Europe was that a patient in the QFR guided group had a higher number of functionally significant study lesions. And this led to a higher number of PCI in the QFR group. If we look at the results, and especially for the primary endpoint that was MACE, a composite of death from any case cause, myocardial infarction, and unplanned coronary revascularization, the QFR performed really worse than the FFR. So the trial was designed to meet the non-inferiority margin, but this not only not happened, but the QFR was deemed inferior to the FFR. What emerged was that the endpoint that drove the entire result was any myocardial infarction, and also there was a statistically significant result for target vessel myocardial infarction and ischemia-driven segment revascularization. What I would like to highlight based on those results is that in the QFR group we have a higher number of myocardial infarction. Why this could have happened? The first reason is that in the QFR group, we had a higher number of PCI performance. And since in the definition of myocardial infarction, there was also pre-procedural myocardial infarction, this could have lead to an increase in the number of myocardial infarction in the QFR arm. Another explanation could be that the QFR having a lower performance compared to the standard of care, to the FFR, could have led to avoid the PCI performance in some of lesions that in the setting of acute coronary syndromes could have been vulnerable plaques. But this reason is not so credible, because the FFR group deferred a higher number of lesions. So this is not a plausible reason. And this is for what is concerned to the myocardial infarction. But as we can see, we have a higher number of ischemia-driven target lesion revascularization and target vessel revascularization. So we have 21 events in the QFR group versus 11 events in the QFR group. And here we have the answer to the question. What emerged is that the negative predictive value of QFR was lower than expected and was lower than FFR. So QFR and the negativity of the lesions didn't perform brilliantly as expected compared to the FFR. This is the main reason why we had a negative trial. About the diagnostic performance, and here we can answer to the question if we can believe to the angiographic derived FFR guidance in our PCI and in our cath lab. There are many studies that have assessed the diagnostic performance and say and affirm that the predictive negative value, so the opportunity to say that the lesion that is deemed the negative by the QFR evaluation is really negative, so does not need stent implantation, are lower than those reported by the vendors, especially if the measurements are not performed by are not assisted by the vendors and are assisted by normal trained operator. Another thing that emerged and that deserves attention and to be remembered also for our clinical practice is that the proportion of stenosis identified by the two methodologies was similar, but in the circumflex and obtuse marginal branches, there was an incredible higher functional significance highlighted by the QFR that did not occur in the FFR group. We have a 37.1% versus the 15.4%. So the diagnostic performance of, especially of QFR, that is the most evaluated tool, is not as good as we have heard. Another thing that we can say, and that also could help us in our clinical practice if we deal with an angiographic-derived FFR tool, is that there are many studies that previously investigated and found that ACS and high IMR values are significant independent predictors of misclassification between QFR and FFR. As you can see, there is the rock curve that depict how different is the result and the performance of the QFR with a low and an high IMR. And this is plausible in our trial, since there are a great percentage of patients with NSTEMI and STEMI, that we could have had an influence from the microcirculation. Again, other than the microcirculation, but together with the clinical presentation, there are studies that says again that the performance in STEMI patients is lower, and this could be taken into account. And what we know from previous study that could have helped to have negative results from the design of our study and the result of the Favor 3 Europe is that there is, as for FFR, there is a gray zone for the QFR, and the gray zone is from 0.75 to 0.85. In this gray zone, there is an incredible higher disagreement between QFR and FFR. Since the median value of QFR in this trial was 0.81, as high the percentage and the opportunity that we had many lesions in the gray zone. And we could consider the credibility of the result, again, if we perform a QFR assessment in our cath lab for those values that are in the gray zone. At this moment, based on the previous study and based on the evidence from the Favor 3 Europe. What I want to say as a last point of discussion is that yesterday was published a subgroup post-hoc analysis in our intervention that focused only on the ferret lesions. So for those patients that were included in the Favor 3 Europe, this subgroup analysis analyzed only the patient that after a QFR and an FFR assessment did not undergo PCI. What emerged is that for the patient that after an assessment did not receive any PCI, the MACE and the result about target vessel MI and spontaneous MI and unplanned revascularization are extremely higher compared with an any study lesion in the feral. What does it mean? It means that if we have a complete exclusion of the possibility to undergo revascularization based on a QFR assessment, there is a higher possibility to do an event. And this is not well explained, that there is no a reason for a scientific based reason. There are a few reasons. I have mine. Maybe I will explain you. So based on the result of the Favor 3 Europe and based on the previous evidence conducted, especially on QFR assessment, we really cannot say that it could be a methodic and a tool we could believe, especially in some contexts. As we said, in IMR context, in patient with STEMI, and also with the result of the Favor to Europe, we are not sure, and we need more results to know if QFR could be really could substitute the FFR. Other studies are ongoing, and we say we will know as soon if there are other technologies that are based on also on angiographic assessment on their reliability compared to FFR. So the take-home message based on this discussion is that the use of QFR for PCI indication led to worse outcomes compared to an FFR-based approach. So the clinical presentation may have played a role, and when the results lead to a complete PCI, the further results appear the worse. There are still unresolved questions related to the credibility of the results, especially in the gray zone for the QFR values between 0.75 to 0.85. Another question that I wanna tell you and wanna say is unplanned revascularization in clinical trial a reliable outcome? And as a final remark, current ongoing studies and refinement in technologies based on those studies will lead to improve those technologies and lead us in the future to increase their diagnostic performance. And that's it.
Thank you, Dr. Giovanni. Very, very nice lesson. May I ask a question? Based on the trials for the acute coronary syndrome in STEMI patients, could we conclude that the QFR performed lower than FFR because of higher, I would say, MI events? So QFR couldn't locate many more lesions in compared to FFR in those kind of studies. So perform lower.
Are you asking about the clinical presentation? So in relation to the clinical presentation?
Yes. Yes.
Okay. In relation to the clinical presentation, the subgroup analysis published as an appendix to the main analysis showed no differences. But as we know, even if pre-specified, the subgroup analysis, given the lower number of patients, and so being not powered for detected the clinical relevant differences, are not so reliable. So there is no direct evidence that there is a result that has been driven from the clinical presentation. But I think that if we read the results, this could be an explanation. So the fact that an IMR, as reported in patient with STEMI and an STEMI, and the clinical presentation could have had a role, and the reason is related to especially to the role of microcirculation. If you perform an FFR in a patient during like STEMI or an STEMI, there is an important role of microcirculation that could lead to have negative result for non-hyperemic tests if you perform instantaneous wave-free ratio, but also have an important drop in the pressure when you administer adenosine, that makes your microcirculation like not working. So and the QFR basically do all the measurements based on a computation fluid dynamic assessment based on different laws, as the Navier-Stokes law. So is something that you obtain indirectly, and is not reliable for, and it doesn't account for the microcirculation impact.
Yes, thank you very much for the complete explanation. Thank you.
You're welcome.
Yeah, nice job, Giovanni. Very comprehensive, despite the time limitation, review of the usability and updated also of physiology.
Prof, I put that question as a final remark. If unplanned revascularization is a reliable outcome, because I believe that it is not a reliable outcome, and I think that also for a balloon, drug-coated balloon, we have the same problem.
You are saying this from which standpoint? From the methodological standpoint? From the
Prof,
weight?
I try to explain myself better. It's just my consideration, but and my consideration is based on the study that yesterday was published on our intervention on this post-hoc analysis. So if you decide to defer PCI based on the QFR result, okay, and the patient knows that he has undergone to an evaluation. We are in 2018 when the FAVO Europe started. So you know that FFR is the standard of care, and your lesion has been tested with a new technology. So you and your doctor and your physician can believe on it, but also there is some degree of of skepticism. Okay, if you have undergone a coronary angiography for chest pain, or also for a clinical presentation like ACS, and you have been randomized to QFR on FFR, and with the QFR there is not a standard of care measurement, you have received a negative result, so you didn't have received the PCI. Okay, I think that in the next year your treating physician, that is not an interventional cardiologist, maybe will increase the number of your visit, and maybe will let you perform again a stress test, maybe a non-invasive ischemic test, and this could lead to also to inconclusive result, but based on the anatomy that is already known, you are biased on the result. This is the first question. Secondly, if you have on your LV an intermediate plaque, and you know that it has been evaluated with a new instrument, I think that the rate of your admission, hospital emergency admission for angina, are higher compared to the ones to the patient who received an FFR based treatment. And this is what happened with for example, with the solution de novo, that all patients that have received balloon, the treating physician here in Spain does not trust too much to the
for solution de novo, we don't have the results yet, so we don't know if this translated into any clinical outcome. But yes, it's so related to DCB. So any new technology can, and in this case, the QFR can determine a higher attention by any physician, not only the treating physician, which could be an expert on that technology, but also other follow-up physicians, leading to an increase in examinations and finding some lesions that in the end get treated, but which could be skipped. So this is your concept, and I agree with you. There is this risk with the novel technologies, and this higher risk can translate into a different clinical outcome. So this is why it is very important to read the papers clearly, and also to weight each endpoint, because for a clinical endpoint study, mortality has a weight, stroke has a weight, and unplanned TLR has another completely different weight. So this is why this is very important when you read a paper, you don't have to read the abstract. You don't have to read the abstract. okay, if I read a paper on mitral regurgitation, that's a topic I don't care about, I just read the abstract because I want to, to get updated on the thing. But if this is something that you work with, coronary disease, if it's an important study, you have to read the entire study and go deep into also the discussion that the authors wrote about this study.
Okay.
But I agree with you. Your point is intelligent.
If you look at the table of the result on the Lancet, it's incredible that for the composite primary endpoint, you have an incredible hazard ratio. You have a curve separation that is incredible. If you look at the single endpoints, it's true. There is an increase in any myocardial infarction. Okay, it's true. But I cannot believe on why.
Also, any myocardial infarction, they have a different weight. So any myocardial infarction, what does it mean? It's just an increase in troponin, 3 or 4 or 5 times.
I saw the definition, and is pretty old. I also focused on the idea that there was, since the QFR guided group led to an increased number of PCI, maybe there was a higher number of periprocedural myocardial infarction, and this is what I've thought, and this could be an explanation. By the way, there are the target vessel myocardial infarction is quite higher. So I don't know. The thing is that the ischemia-driven measured the segmental revascularization for the study lesions led to the doubling. There was a double the number of patients that underwent ischemia-driven segmental revascularization. There were 21 patients in the QFR group and 11 patients in the FFR group. And this, I think, is an eloquent result that we could keep in mind, like for the future. Because for the death, there is no difference in death. There is no statistically different for any unplanned coronary revascularization. There is no difference in target vessel failure. There is just this difference in any myocardial infarction. That is something that I don't know. I can believe. So it's true that I admit that the negative predictive value of QFR maybe is not that negative. It's true, but it's expected. It's an angiographic derived measure. It's not an invasive measure. You don't put a guide wire. You don't perform adenosine. So what would you expect? That is better? No, couldn't be. But the results of this trial does not make drawing any conclusion.